Good morning, everybody. Thank you, as always, for joining with us. We have a really great presentation today for you. Before that, we have a couple brief updates, and I'll start with Dr. Dunn to kick us off.
Good morning, everyone. Happy Hispanic Heritage Month and happy Disabilities Awareness Month. This is also Diversity Week, and we're very excited to hear Dr. De Jesus Perez's talk today. But first, I just wanted to give you a couple of announcements regarding some things that are happening around the department, around the School of Medicine in general. So as you know, it is Diversity Week, and there have already been some wonderful activities. Later on today, there will be the Pandemic Puzzle Symposium, although that is happening concurrently. That'll be a little hard to make it to, but the 4th annual LGBTQ+ Forum is happening today from 3 to 6:20 p.m. Tomorrow, the Stanford Medicine Abilities Coalition, SMAC, and the Stanford Medicine and the Muse present a theater production called Alone in the Ring. And it is going to be a research-based theater production about inclusive workspaces for healthcare students and professionals. Lastly, on Friday, October 15th, there's a Latinx ERG Hispanic Heritage Month event from 11:30 to 1. And the keynote speaker for that is going to be Robert Rodriguez. As part of our Hispanic Heritage Month programming, we are very thrilled to welcome poet, essayist, and physician Dr. Rafael Campo. He is from Harvard Medical School, and our inclusion rounds will include his talk entitled Poetry and the Importance of Voice in Diverse Illness Experiences. That's going to be October 21st at 12 p.m. and we hope you can all make it. As I mentioned, it's Disabilities Awareness Month, and we'll be talking much more about this in the upcoming weeks. But for some activities that are happening this week, I wanted to alert you to Alone in the Ring, as I already mentioned. That's the Inclusive Workspaces theater production. And then this weekend will be the Superfest Disability Film Festival, which celebrates disability in the arts. That's going to occur from October 15th through 17th. And I urge you all to take a look at the SMAC website or their social media at Stanford SMAC for some activities, as well as some podcasts that have happened that have featured Peter Poulos and others. So they have a really active website and an active social media Twitter account that you should all check out. And we will give you more information about Disabilities Awareness Month later. Next. And last but not least, we had the Stanford Meharry Initiative Research Retreat yesterday. Departments, radiology, pathology, and medicine all welcome Meharry medical students to do some research. And this year, 2 of our very wonderful abstracts received awards, one of them being the People's Choice Award. This was Matthew Burke, who is a second year at Meharry, who had a project entitled 5-Minute Moment for Racial Justice with Samantha Wong. Congratulations to him. And also Lauren Cobb, also a second year at Meharry, got the most outstanding project overall. And her project was entitled Impact of Race on Graft Survival in Patients Undergoing Liver Transplantation. And she did that along with Allison Kwong and Ray Kim. So congratulations to both of them. And thank you all so much.
Thanks so much, Dr. Dunn, as always. Just want to mention upcoming next week, we have Dr. Carlos Bustamante who will be presenting. He's going to be talking about the how our genetics play a role in, we were always wondering how some people get really sick, some people don't. He's done a lot of research in this area that's been gotten a lot of attention. So he's going to be talking about the genetics that help perhaps explain somewhat how some people get sicker and some don't with COVID-19. And then the following week is Dr. Don Berwick, who will be talking about the moral determinants of health. With that being said, I'm going to now turn it over to Dr. Mark Nichols, who will be introducing Dr. Perez, De Jesus Perez, as well as emceeing the rest of this. So Dr. Nichols, thanks so much for taking over.
Thank you, Errol and Tamara. It's a true honor and pleasure to introduce Dr. Vinicio De Jesus Perez, who is an associate professor of medicine in the Division of Pulmonary Allergy and Critical Care Medicine. Vinicio did his undergraduate work, graduating summa cum laude at the University of Puerto Rico, where he stayed for medical school, and his internal medicine residency at the Mass General. He was the first to matriculate there in this program from the University of Puerto Rico. He then went on to Denver and finally Stanford for his pulmonary critical care medicine training. And at Stanford, he trained in the laboratory of Dr. Merlene Rabinovich, who has created a legacy of great independent investigators around the world, including at Stanford. Before becoming a UTL faculty member in our division, he began his work doing KO8 research on pulmonary vascular biology. And in our division, he has thrived as a faculty member and has become an important leader, not only for our group, but for the department and for the School of Medicine. Vinicio is an NIH-funded investigator with multiple grant awards, including several R01s, R25 and an R21. He leads a productive laboratory, recently moving out to beautiful Stanford Research Park. For those of you who haven't visited out here, he works in a laboratory which is being equipped with millions of dollars of cutting-edge cardiopulmonary phenotyping equipment, and works collaboratively with a number of pulmonary vascular researchers. As an aside, for those of you who don't know, Stanford arguably has one of the finest pulmonary hypertension programs in the world, and Vinicio is an important reason for this. He is published widely in our field's top journals. Importantly, Vinicio has been an effective local, national, and international leader promoting diversity and inclusion. He is the PACCM Director of Faculty and Fellow Diversion and Inclusion. He's the co-director of the Stanford Translational Investigator Program, otherwise known as TIP. He's a standing member of the Ribbit NIH study section, which is the study section that evaluates pulmonary hypertension proposals. And he's chair of the Pulmonary Vascular Diseases Consortium. He is a member of ASCI. Vinicio is a great mentor and has shepherded the careers of a number of students and fellows, including Kei Yun, who is now an R01 funded investigator, assistant professor at Harvard. We are really looking forward to hearing his talk this morning on angiogenesis and pulmonary arterial hypertension. And with that, I will turn the podium over to Vinicio.
Marks, thank you so much. It's an honor, a privilege to be here and to share with you my work. So, for everybody in the audience, muy buenos días a todos. Today, we're going to be talking a little bit about science, about medicine, and all the things that happen in between. Now, all of you probably got the Shakespeare reference of et tu, Brute, but you probably were wondering about that word, angiogenesis. Now, if you are like me, the first thing you will do is to do a Google query. And if you go for angiogenesis, the first thing, at its most basic, angiogenesis is the development of new blood vessels from pre-existing vessels. It plays a fundamental role in embryonic development, tissue repair, inflammation, as well as neoplasia. Now, here's where things start to get more interesting. Angiogenesis can be a vital part of the pathogenesis of many disorders. However, the contribution lies on whether there's too much or too little angiogenesis. In cases such as cancer, diabetic retinopathy, and atherosclerosis, too much angiogenesis contributes to disease initiation and progression. So inhibition of angiogenesis is a appealing target, and it's certainly being exploited therapeutically in the field right now. However, there are other disorders where too little angiogenesis is a problem. In the context of heart attacks, where hypoxemia is associated with loss and obstruction of blood vessels, fractures, peripheral vascular disease, even male portal burners. And in these disorders, it makes sense to actually stimulate angiogenesis. So if you're going to take something from this talk, is the fact that angiogenesis is a very powerful process that must be kept within a range of function, and too little or too much is an issue. Now, for me, as I tell you about the disorder, pulmonary hypertension, it will make sense why angiogenesis is such an important part of this. So on with the show. Pulmonary arterial hypertension is a rare disorder associated with high blood vessels in the lungs and right heart failure. It affects an estimated 400,000 people worldwide. The mean age of presentations is 50 to 65 years of age with a female predominance. The pathology is associated with pulmonary vascular obstruction of blood flow. This is associated to pulmonary vasoconstriction, remodeling of the vessel wall, fibrosis and inflammation, as well as in situ thrombosis. The end result is that as the pulmonary vascular resistance increases, right ventricular afterload increases, thus leading to a state of right ventricular decompensation. Now, there are 14 FDA approved products and more on the way. So for a rare disease, this is quite extraordinary. However, as we will talk later on, there are only 66% of patients, despite our best efforts to treat, that survive 5 years post-diagnosis. Now, let me tell you about what we understand about the pathology, because this is going to be really important as we move further into the role of angiogenesis. So let us revisit the lung vasculature in health. This is a perfuse explanted lung. You can see the beautiful branching structure of the pulmonary vascular tree, which mimics that of the airways. If we look at the alveolar level, this is your pulmonary artery, this is your pulmonary vein, and this is, of course, the alveolar capillary network. If we look at the structure of these microvessels, you can see they have a very thin wall. It's endothelium, some smooth muscle cell coverage, and here you can see that this is the alveolar space, and it makes sense. You want to get blood as quickly as possible, capture oxygen, release CO2, rinse and repeat. The vasculature also is finely tuned to modulate levels of perfusion, but also to ensure that the endothelial cells in these vessels remain happy and in a homeostatic state. A major part of this is the presence of these cells called pericytes, which wrap themselves around the capillaries to modulate perfusions, but also to supply much needed growth factors and maturation factors to keep the blood vessels happy and viable. This results in a network where the blood vessels and the pericytes create a web that ultimately creates a wide surface area for gas exchange. Now, when we look at pulmonary hypertension, the first thing that strikes us is that there are very few vessels, and the vessels that remain look crooked because the pressures are increasingly high in this setting. Now, if we go even further into the histopathology, you will see that rather than those thin wall vessels I show you, now you have obstructed vessels as a result of an increase in cell growth that ultimately invades the lumen, creating obstruction. You may have lesions such as this one, where the lumen is actually plugged by a thrombus. And you can see these, which are considered the pathognomonic histological finding in pulmonary hypertension, the plexogenic lesion. And what you can see here, and we'll look in more detail later on, is a cluster of blood-filled channels that ultimately trap the blood and do not allow it to move forth. Why is this important? In the patients with pulmonary hypertension, we see a wide distribution of these lesions in both lungs. There's no imaging tool that allows us to really gauge the severity of the disease in real time. But what we we know is that as these lesions accumulate and the vascular narrowing becomes more severe, hemodynamic impairment becomes worse. Pressures go higher, pulmonary vascular resistance goes higher, cardiac function deteriorates. And at the same time, you see that progression is linked to a loss of these microvessels that normally will take blood to the alveoli. And it is this combination of obstruction and vessel loss that ultimately leads to progression and, in many cases, the death or the need for transplant. There are 14 FDA-approved therapies, as I told you, and they go all the way from oral agents like PDE5 inhibitors, endothelin receptor antagonists, and the most potent of the medications, which are the prostanoids. And these can be orals, they can come in inhaled form. More recently, we're transitioning from nebulized forms to dry powder inhalation. And of course, the ones that you probably see more often when you work in the CCU with us, it's the parenteral prostanoids. Patients need to live with these pumps connected either through a Hickman catheter or subcutaneous to deliver the medication. So these can be quite invasive, require a huge change in quality of life. So is it worth it? The answer is yes. The survival for pulmonary hypertension over the last 20 plus years since the introduction of the first prostanoids have dramatically improved. But over 5 years, as I hinted in my introduction, you can see that the disease, it remains progressive. More patients, despite our best efforts, die out. And right now, the 3-year survival is 68%, at 5 years, 57, 7 years, 49. So despite our best efforts, our patients continue to progress and die. In other words, the 14 drugs that we currently have are not enough. They work, they are beneficial, but they're not enough to halt disease progression. And why is that? And this is actually where we now go into why it's important to understand what makes pulmonary hypertension tick at its most basic level. Now, if you think that about the following, the 14 drugs that we have, all of them are vasodilators. They actually target healthy blood vessels that can still be open. But when you look at the pathology of pulmonary hypertension, it is hard to imagine that a vasodilator will be able to actually do anything around this. In fact, if we look at the pathology, we can learn a lot of things about the disease itself. Look at this lesion here. This is not a simple lesion. This is a highly complex lesion. But if you look at this, you can ask many questions that ultimately you can take to the lab and try to examine with animal models and cell-based models, as I will show you in a moment. But for example, looking at this, you actually see areas where there's smooth muscle cell accumulation. And within these, like here, for example, you can see endothelial cells that are actually trapped. You also have these vessel-like angiomatoid lesions where you see a large amount of blood that appears to be pooled. Why is this vascular malformation present? Then you also have, and I'll show you this, a recently discovered connection between the bronchial arteries and the lesions in pulmonary hypertension. And this is important because many of our patients with pulmonary hypertension can present with massive hemoptysis. And this is actually the source of this. And of course, the plexogenic lesion at its most basic has always been seen as a reflection of failed efforts to generate new vessels. So the major challenge for us initially was, the major limitation here is that all the the histology that we can use is limited to what light microscopy can show us. But these are very complicated lesions. So we wanted to go further. We wanted to really understand the complexity of the pulmonary vascular lesions. So for that, we collaborated with Karen Trent-Lundmark, a good friend and professor at Lund University, to use synchrotron-based CT imaging. What this does is it takes a magnet and it uses X-ray particles to hit your sample, in this case, a paraffin block of tissue, and can capture, it can make a reconstruction of the tissue in exquisite detail that allows you to also build 3D models of tissue, particularly vessels. So with this, for example, you can see this is your traditional 2D microscopy. This is a healthy lung, and this is what the synchrotron can give you. You actually can go really deep into your tissue and get unprecedented access to the anatomical detail. And with that, we have now made some fantastic observations, unprecedented in regarding to how these lesions look like in the lungs of our patients. Here, for example, is contrast that we injected into a pathological sample from one of our patients, and we have created a three-dimensional image. So, for example, this here is the vessel lumen, right? You can see here in this three-dimensional cut, this is actually the media and the adventitia yourself. Now here, what you can see, this is a plexogenic lesion, and what you can see in this spider-like structure, it actually is connected to the lumen through a pedicule. But there's also these structures that actually dig into the adventitia and feed on the vasa vasorum, which are the vessels that feed the vessels, so to say. And this is actually surprising because if you were to look only at 2 dimensions, it will be hard for you to know the relationship of this lesion to the actual vessel. See, here, this is what you will see with your traditional microscope. This is what we're seeing now. But what we were actually surprised to find, and an unexpected finding was, we found that there was not just one plexogenic lesion, but 4 plexogenic lesions, and they're all distributed. So the one I show you right now before is this one. You can see it on the periphery of the vessel, but we also found this lesion, which actually is connecting a pulmonary artery with a bronchial artery right here. We also saw this lesion where the blood vessel is essentially blocked by one of these plexogenic lesions. So it's a dead end, as you can see here. And then you actually have these lesions here where the plexogenic lesion is inside the lumen. This gives us, for the first time, an unprecedented view of what the pathological burden of these plexogenic lesions provide. But it also raises, in my mind as a scientist, the question, this all suggests that there's an effort for these vessels to form, although the process that actually drives angiogenesis appears to go haywire in patients with pulmonary hypertension, which now leads to the second movement of my presentation, which is why at a genetic and molecular level, how do we go from this to this? Well, there are many theories of what triggers the pathologic changes in pulmonary hypertension, but one of the most favored theories is that it all starts with an insult to the endothelium, which triggers a state of endothelial dysfunction where the endothelial cell normally will regenerate damaged cells and lost vessels to keep things stable. But in the context of endothelial dysfunction in PAH, we actually see an activation of an inflammatory response that remains persistent. We also see pathological changes in cells surrounding the endothelium, like in the medial layer. We see phenomena such as endothelial mesenchymal transdifferentiation and the appearance of endothelial cells that actually have a phenotype that is highly aggressive and lacks the same initiative to form vessels. It rather grows and expands, and ultimately it's a combination of these events that leads to the obliterative remodeling. Now, why will the endothelial cell upon injury trigger these abnormal responses? And that is the question that has kept many of us in the field for many years. Inflammation, which Dr. Nichols has studied in great details, drugs and toxins, which we have discussed with you in prior grand rounds, endothelial survival, BMPR2 mutations, DNA damage. These are all aspects that have been explored and shown to contribute and serve also as a rationale for drug therapies. But the one that has fascinated me for the last 15 years has been this issue of angiogenic inefficiency, which in its simplest term is the fact that the endothelial cell does not know or does not remember how to appropriately form a vessel. And this is what my lab has been built upon. And today I'll tell you 3 stories that we've been working over the past couple of years. One that has to do with how endothelial cells form blood vessels and why that may not be happening in PAH. One about how endothelial cells and pericytes initiate this partnership, which in PAH appears to be lost. And then I will finish with some exciting directions of how we can hijack some of the concept that we have been learning over the past couple of years into therapeutic initiatives. So let's jump right into it with the endothelial cells. So let's understand something from the get-go. The process of blood vessel formation is very well organized. You have an injury in your blood vessel. To regenerate that vessel, you need to trigger the endothelial cells from the remaining vessel to actually coordinate a movement whereby there is organized proliferation and motility towards the area where the blood vessel was occupied. This may include branching, but ultimately, then when the basic groundwork of the blood vessel is established, the pericytes then are recruited to provide structural support. This is a very complex process, and you can imagine there's a lot of molecular players involved, but no factor is as important as the VEGF signaling pathways. Many of you have heard of the VEGF signaling pathway. The vascular endothelial growth factor pathway is a key player in angiogenesis everywhere you go. The way it works, and this is very simplistic, but in the setting of, for example, hypoxia, where you will need you need oxygen supply that a blood vessel provides, the HIF factors will actually trigger the expression. These are transcription factors that then trigger the expression of VEGF and other angiogenic genes, but particularly VEGF is produced, which when released into the environment of a blood vessel triggers the endothelial cells to actually initiate the angiogenic. VEGF is a very powerful pathway. You can see here how many downstream signaling events it triggers, but the fact is all of these are involved with one aspect of the angiogenic process, such as survival, vasodilation, angiogenesis, and beyond angiogenesis itself, VEGF is critical for vessel maintenance and repair. Now, this is actually, again, another example of how a picture may betray the complexity of this vital process. This is your blood vessel here, and what you can see here are the branches of new blood vessels that are arising towards the periphery. This does not tell you the same story as if I were to show you this movie where the endothelial cells, these are the nuclei, they almost look like ants working near an ant nest. What I want to point out is that these endothelial cells are in motion, but they're not disorganized. They have a very coordinated movement. And the reason for that is the appearance of this endothelial cell called the tip cell. VEGF actually triggers some endothelial cells to assume this phenotype where the endothelial cell changes from what you normally associate, this sort of cuboidal cell that is big, you know, it's like a brick in the wall of the endothelial layer. This guy is actually armed with these structures called filopodia, which actually act as antennae. So in a diagram, you can see this is your tip cell, what I just showed you. You can see each of these little tendrils is actually a radio antenna that is exploring the environment, looking for VEGF and other signals so that the growth of the vessel can be directed in the direction that it's required. So VEGF is important in that. So the first question in your mind is, well, what do we know about VEGF in these lesions of pulmonary hypertension? Well, last 20 years has shown us many studies, particularly this one from leaders in the field like Norbert Focal, Carleen Kuhl, and Ruben Tudor, where staining immunohistochemistry of lung tissues from PH patients against VEGF and its receptor, VEGF receptors, do show that these peptides are abundant in the lesions, and these are lesions that are very rich. You can see here the vascular channels line up with blood vessels. So if you look at this, the first thing you will conclude is, well, there's a lot of VEGF, there's a lot of VEGF receptor. Obviously, these endothelial cells must be avid for VEGF, so they must be having increased activity upon VEGF. Well, what if I tell you that the opposite is true? If we actually take endothelial cells from the patients with pulmonary hypertension, compare them against healthy vessels, and seed them in matrigel, which is a substrate that allows endothelial cells to actually form tube networks. If I stimulate with VEGF, you can see that the healthy cells form these very nice frameworks, these tube networks, but the PH cells, even if I'm giving them VEGF, are not doing that. If I look even deeper, I see that again, as you will expect, when you add VEGF, tip cell formation is actually very easily seen in the healthy cells. You can see they look like snails, right? But these are your filopodia, and you can see that there are multiple tip cells, and you know that they're going to start branching out to create this network. But in PAH, very few of these endothelial cells actually form the filopodias. These filopodias appear long, and they lack the defined morphology as healthy. And if we go even further and do electron microscopy, you will see again that you have the endothelial cells from healthy patients. They're covering this little filopodia, and they even have this sort of mop top, if you will. You can see this filopodia here exploring the environment, but in the PAH, it almost looks like an axon knob. You will see it's actually totally blunted. And again, look at the morphology of these filopodia. So this led us to speculate that the problem here in PAH is that there is an impairment in tip cell formation in response to VEGF, and without a tip cell, you cannot form a healthy vessel. Just to summarize what is now almost 10 years of work, what we found is that the problem is not necessarily VEGF signal, is that VEGF needs a partner in crime, so to say. Another signaling pathway that allows signal modulation so that the VEGF signaling can remain within the parameters necessary to trigger all the right downstream signaling events. This pathway is called the Wnt 7A signaling pathway. And you can see that the receptor of the pathway, called ROR2 right here, partners with the VEGF receptors, and together they form a signaling complex that ultimately triggers angiogenesis required for preservation of the pulmonary circulation and the microvessels. In PAH, we found that this Win7A ligand is not properly produced, so VEGF is left unbalanced. And it is as a result of this that we believe you actually have abnormal angiogenesis and progressive vessel loss. Now, we have gathered a lot of data, but I think these movies actually illustrate this process very clearly. These are organoids that we put together by combining pericytes and endothelial cells and suspend them on a 3D collagen gel. These are your healthy donor endothelial cells stimulated with VEGF, and over a period of 10 hours, you can see the endothelial cells reaching out, sprouting from that. Whereas the PAH cells, again, doesn't matter how much VEGF you give them the same amount of VEGF, there's nothing. The cells are they just keep ruminating there. But if you now give Win7A with the VEGF, you now can see that the healthy cells, there's more of this of these sprouts. In particular, now the organoids look like urchins. But what's really more important is that you can take the, this is misplaced, this is PAH. You can take a PAH cell, add VEGF and Win7A, and then you can create, you can allow the cells, which initially were not responding to VEGF, to now sprout in response, which shows you that there may be a therapeutic potential here. We could potentially find a way to restore Win7A in this setting. We also took a look at animal models. In this model, we actually took Win7A, so we took out one allele. We knocked out one allele of Win7A. So these animals are heterozygous. We exposed them to hypoxia for 3 weeks, which is a known model to stimulate pulmonary hypertension. And then we measure pulmonary pressures. We look at right ventricular structure and vessel morphology. Under normoxic condition, there's no difference in right ventricular pressures or in RV remodeling between the wild type and the Win7A heterozygous. But when you expose the animals to hypoxia, you can see that the Win7A heterozygous has more severe pulmonary pressure and more severe right ventricular remodeling. We actually went ahead and, there you go. We went ahead and actually isolated endothelial cells from the lungs of these animals. And again, just like the human cells, you can see that here's the wild type, here's the Win7A heterozygous. The endothelial cells from the Win7A heterozygous also produce smaller tube networks compared to those you see with the wild type under VEGF. But again, if you add Win7A, you can certainly induce those endothelial cells from the heterozygous to suddenly recover the angiogenic capacity that will lead them to form more vascular networks. Now, this is taking one allele. What if I take both alleles, both Win7A? So this will be a full knockout. Well, we give the animal tamoxifen to induce the knockout in an adult. I mean, if you try to take out Win7A in utero, the problem is that the animals grow and they're infertile, so it's hard to expand them. But what we were shocked to find is that after 5 days of tamoxifen, after knocking out the Win7A, all our animals died. And this was actually quite surprising. We actually found that the animals in necropsy, we found some animals that had this tumor-like nodules in the lung. We saw that the animals had significantly enlarged hearts. But what was really shocking is that when we look at the lung histology, we actually find not only that there's vascular friability, but we also had areas where there was a huge expansion of cells. And these cells involve alveolar epithelial cells, endothelial cells. So at this point, what we can conclude is that Win7A is a fundamental key peptide that is required for lung homeostasis. And this is beyond pulmonary hypertension now, which is why we have actually recruited our colleagues from Tushar Desai's lab, Nick Jewell, Matt McCarr, as well as Robert Wynn, a tumor biologist, to help us further elucidate, because we find ourselves with a very powerful peptide that we believe can tell us a lot about lung homeostasis and about different lung disorders. Now, leaving behind the endothelial cells, let's talk a little bit about pericytes, and my other favorite cells. Now, pericytes are quite fascinating cells. They are actually located at the level of the capillaries, and compared to other cells, what makes pericytes unique is that they actually envelop the blood vessels. They establish connections, physical connections with the endothelial cells, where they can actually share organelles, they can share cytoplasm, and they also create an extracellular matrix that envelops them both. And this is going to be important, so keep that in mind as we head to the final part of my talk. You need endothelial cell pericyte interactions. You need them. You need them. If the endothelial cells and the capillaries do not produce these connections, the blood vessels simply break apart. And this is the basis of many cardiovascular disorders, such as neurovascular disorders like Alzheimer's, cancer, where not recruiting pericytes leads to leaky vessels, which are easy for tumors to send metastatic cells out. Excuse me. Diabetic retinopathy is probably the most common pericyte disorder that you will see in clinic. Stroke, and then pulmonary hypertension, which is something that I got interested in when I was working with Marlene Rabinovich as a postdoc. So one of the first things we did was, where are the pericytes in the lung? Well, in a healthy donor, the pericytes are where they're supposed to be. They're associated with capillaries and microvessels. You can see them very adjacent to the green, which are the endothelial cell layer. But in PAH, what we ended up seeing is that in this giant valley of matrix and cells, the pericytes are detached from the blood vessels. You can see it here. So don't matter what lesion, this is actually a plexogenic lesion that looks like a sad face, right? But you can see the pericytes here. This is a more muscularized, but in all of the lesions we saw the same pattern. The pericytes are not connecting to the endothelial cells. When we isolated the cells from the lungs, we took PAH endothelial cells, and again we throw healthy pericytes at them. And what we found is that in the context of, even if you throw healthy pericytes, when you put healthy pericytes and endothelial cells, you form these nice thick networks, which you can see here in red, the pericytes, in green, the endothelial cells. If you add PAH endothelial cells and throw a healthy pericytes, the pericytes do not associate very well with the endothelial. It's almost like there's something missing that the endothelial cell is not providing to actually recruit the pericyte. Okay, so we were interested in Wnt signaling based on our work on the Wnt7A. So we decided to ask whether Wnt's may be playing a key role here. And what we found is that when we co-culture endothelial cells and pericytes, and we look at the Wnt expression profile that endothelial cells generate, we can see that in the context of pericyte exposure, endothelial cells from healthy lungs generate this specific ligand called Wnt5A. But the PAH cells are not generating that. And this was really interesting because it led us to speculate that maybe this Wnt5A production by endothelial cells is sort of the trigger that tells the neighboring pericyte that, you know, they need to come in and dock on the surface of the blood vessels so that the endothelial pericyte formation forms. Indeed, you can see here, this is an endothelial cells culture alone. If you put the healthy endo with the healthy pericytes, that endothelial cell suddenly starts packing Wnt5a in green into these little packages called exosomes, and they start being released, which we believe is the way that Wnt5a makes it to the pericyte. So the pericyte is alerted that its time has come. In PAH, you can see that there's very little Wnt5a being produced. And even when you add the healthy pericyte in this context, there's also very little Wnt5a that gets packaged into these exosomes. But again, in addition to a lot of this in vitro work, we decided, well, what if we take Wnt5a, we knock out Wnt5a from the endothelial cells of a mouse and put the mouse in hypoxia, just like we did with Wnt7a. Well, initially, under healthy condition, under normoxia and hypoxia, we actually didn't see much difference between our wild type and knockout. But when we put the animal back in recovery, in that setting, usually the animals go back to normal, pressures go back down, and blood vessels actually recover. They go from being muscularized to normal. In the case of the wild type, we saw a nice recovery, a nice a return to baseline. But in the Wnt5a knockout, we saw a persistence of the pulmonary hypertension. We saw persistence of the RV remodeling, more dramatic in these echocardiographic images. This is your right ventricle right here. Look at the right ventricle in this Wnt5a animals. And this is after return to recovery. So there's persistent pulmonary hypertension and persistent right ventricular remodeling. So of course, we got very excited to see what was happening to pericytes in the lungs, as well as the blood vessels. So, oops, excuse me. In these images, this is a CT angiogram from explanted lungs of these animals. Again, this is all animals in recovery. You can see that compared to the wild type, where you can see the nice branching of the vessels in the knockout animals, you actually see a lower density of microvessels reaching the periphery. There is significantly lower vessels and lower number of vessels and higher number of muscularized vessels in this knockout. And of course, when you look at the pericytes, what you end up seeing is that in the wild type, your pericytes are associated with the microvessels. You can see them very easily here connecting to the endothelium, whereas in the combined knockouts, there's fewer pericytes associated with the vessels, and the vessels that remain actually have a thick layer of smooth muscle cell, which is a pathological hallmark of pulmonary hypertension. So based on this model, we concluded that Wnt5a is required for establishing a balance of endothelial-pericyte interactions in the lung. Without Wnt5a, you may fail to actually recruit pericytes to the vessels. So the model we currently have here is that you need this pathway, this Wnt signaling pathway that I'll not get into detail, but Wnt5a is required for endothelial cells and pericytes to actually communicate so that an interaction can be established. And this is important to maintain vascular homeostasis. But in PAH, not having that signaling pathway will lead to a state in which endothelial cells and pericytes are separated. Now, of course, this is all about endothelial cells, but if the pericytes are not associating to endothelial cells, what are they doing, right? That's the question. Well, we decided to actually take healthy endothelial cells and expose them to PAH pericytes. Now, this is the reverse of what I showed you originally, where it was PAH endothelial cells and healthy pericytes. Now we want to know what is, if there's something intrinsically abnormal about PAH pericytes when they encounter a healthy endothelial cell. Well, here's a movie that tells you these are healthy endos, healthy pericytes. The healthy pericytes in red, these are the endos in black and white, you can see that the healthy pericytes associate very nicely. They love to interact with the endothelial cells because that's what they're supposed to do. But look at the context of PAH. These pericytes are not interested at all in interacting. They sort of get dragged by the endothelial cells. They get like pulled. They're almost like a Stretch Armstrong toy. They don't move, they're just being pulled. So it's almost, if you look at it in sort of a fun way, these guys are ready to boogie down with the endothelial cells, whereas in PAH, the PH pericytes, they're really not impressed. They're really not motivated to actually do anything. So what are the pericytes doing then? Well, I'll tell you, this is using another animal model. This is an animal model where we can actually target neural cells. In particular, you can see this model allows us to tag pericytes in red, as well as some smooth muscle cells. And what you can see, this is in healthy conditions. The pericytes, again, are associating with the microvessels in the lung. You can see that nicely. If you expose the animal to 21 days of hypoxia, the pericytes suddenly detach from the microcirculation, they appear to sort of concentrate in areas where the vessels are being muscularized. So a diagram of this can be seen here, where your pericytes and smooth muscle cells seem to be in separate spaces, whereas with hypoxia, when the vessels become muscularized, suddenly the pericytes and the smooth muscle cells seem to coexist around the same environment. How the pericytes get there, what are it's part of what Dr. Chen Yuan is exploring in her R01 grant. For us, another interesting observation is that these pericytes are highly contractile. So we have been very interested in looking at particularly what's happening to these guys. So these are control and IPH pericytes in a gel contraction assay. You can see that their contractility is much higher compared to controls. If we add Win5A, which is a stimulus from endothelial cells to pericytes, we actually find that Win5A can trigger some contractility in pericytes, but this is significantly greater in PAH. And if we do a calcium flux assay, you can see here how calcium enters very quickly. These are action potentials within the pericytes. You can see how quickly the calcium enters. The flash means calcium is in the cytoplasm, and then it goes into the circa or is shut out of the cell. So, but in PAH, it looks like the calcium signal is already high at baseline, and it actually is much slower to clear. These are abnormalities that we think may be related to the fact that there's another Wnt pathway in PAH pericytes, which is associated with calcium signaling. And through this pathway, the pericyte is switching from the Wnt-PCP pathway that I told you about, this Wnt7A ROR2 pathway, to this Wnt calcium pathway, which allows the pericyte to become hypercontractile, hyperproliferative, and ultimately it may be contributing to vascular remodeling. And then, of course, one thing that we're also interested in is that the pericyte can actually act as an immune sentinel cell. It actually can trigger immune responses in the perivascular space. This is well established in the brain, but in the lung, it has not been explored. And work by Dr. Nichols and Rabinovich have shown that inflammation is a key driver in pulmonary vascular responses. But how do we get that inflammation in the first place is actually a subject of interest. What David Condon, who's actually one of our pulmonary fellows, what he has discovered is that PH pericytes have a transcription factor called LITAP that serves as a master regulator of immune responses in the pericyte, which can trigger not only cytokine production, but also the recruitment of immune cells to the perivascular space. This also can allow these cytokines to influence endothelial responses and integrity. And this is the work that he's currently pursuing in the lab. So more of that probably in the future as he continues to elucidate this. So in the final few minutes, I'll tell you a little bit about how we are now targeting angiogenesis with what we have learned. So now that I've told you how important endothelial cells and pericytes are to the process of angiogenesis, obviously in your mind with what I've told you, it makes sense to think, well, if the problem is that endothelial cells and pericytes are not putting themselves together, if we could find a way to bring them together, maybe that will be a way in which we could potentially facilitate angiogenesis. And you may be right. In fact, we are currently trying to do that with some Wnt modulators in the form of exosomes based on the work that I've told you. But there's also work by other colleagues in the field that are using other approaches like endothelial stabilizers, such as sotatercept, tacrolimus, and BMP9, which I'll not go into detail, but I'll refer you to this recent review we just published in Chest. And then some gene editing approaches that Dr. Rabinovich has actually pioneered here at Stanford. But, you know, so the problem here is that, you know, it's difficult to think about specifically targeting a pericyte, specifically targeting the endothelial cells. But what about if you could target the extracellular matrix? In other words, the glue that keeps these cells together. Now that's an interesting question. The extracellular matrix is fascinating because it serves, it's not just the scaffold that brings the cells together to keep them aligned in these structures within the lung. It's a very highly complex and dynamic tissue that controls anything, anywhere from mechanobiology to cell signaling in specific cell types. In fact, you can actually take a tissue, you can wash away all the cells and leave the extracellular matrix alone, and then you can actually feed the cells back in and potentially reconstitute that whole organ. And that's actually one of the strategies currently being explored to solve our organ transplant, our organ supply crisis. If you look at the structure of the extracellular matrix, it's a highly complex tissue made up of proteins like collagens, for example, laminins. And then there's this very interesting glycosylated molecules called glycosaminoglycans.
Hey, Vinicio?
Yeah.
Do you want to wrap up a little bit? We're getting really close to 9 o'clock.
Not a problem. I'm almost done.
Okay.
Yes. So this hyaluronan provides support that allows cells to actually work together and establish the foundations of a vessel. Hyaluronan is highly expressed in the context of pulmonary hypertension, and it's associated with vascular pathology. There are higher levels in the circulation of these patients. So one question is, could inhibiting HA allows us to restore the extracellular matrix so that endothelial cells, pericytes can establish their communication? And there's a precedent for that in studies of lung fibrosis, where you can see we can actually have instances where the lung fibrosis can trigger pulmonary hypertension as a result of damaging the structure of the blood vessels. In the context of IPF, Paul Bolicki and Harry Kermudi-Quintana have tested a compound called 4-MU, which inhibits HA synthetases, the enzymes that produce HA. In this context of bleomycin, which is a model of fibrosis, you can see that use of 4-MU can substantially reduce the level of fibrosis and restore some of the structure, which is seen also, if you look at the blood vessel, there's significant vascular remodeling here. This is smooth muscle actin, which tells you about hypertrophy. And you can see that in the context of 4-MU, there's a significant reduction in the level of muscularization by reducing the burden of HA. So this is now what has served as the basis for this clinical trial we're putting together, the Saturn study, which is sponsored by Catalyst and which we're doing in partnership with Halo. It's going to be a randomized double-blind placebo phase 1/2A study. We're going to use a group 1 and 3 PH patients randomized to oral H1 or placebo for 24 weeks. Our primary endpoints are going to be safety and tolerability and looking at pulmonary vascular resistance, which tells us about the extent of vascular remodeling in the circulation. And we're going to also look at hemodynamic changes, quality of life scores, and changes in the biomarker, which is serum concentration. So we are very excited about that. This is a step forward that takes us towards thinking about what is angiogenesis contributing to PH pathogenesis, to how can we target angiogenesis. So with that, I hope I've convinced you that PAH is a disorder of vessel loss and inappropriate angiogenesis, that these complex lesions that we've identified contribute to the vascular pathology and provide insight into the mechanism. We believe Wnt signaling is a critical player here. We believe hyaluronan is a key player that modulates cell-cell communication in the pulmonary vessels, and we're hoping to show that by targeting HA, we can potentially restore angiogenesis and provide a new therapeutic avenue for PAH. So with that, this is my team. It's an amazing team. We could not, all this work is due to them. Takes a village around the world. These are all my collaborators, but I want to point out Dr. Roham Samani and Nicholson Rabinovich, who have been my close collaborations and mentors across the years. And again, I want to point out that 3 of the members of the group, Sean, Ramon, and John, have been internal medicine residents, and we're always open to mentor and share the joy of research with our trainees. So anyway, I'm very grateful to you for this opportunity today, and thank you so much for your attention.
Thank you, Vinicio. Well, unfortunately, we're at the top of the hour. For those of you who can stay on for a few minutes, maybe we can just ask 1 or 2 questions. Professor Edward Leibowitz asked the question, the pathology looks the same as Jesse Edwards' descriptions in the middle of the last century for congenital heart disease. Dr. Leibowitz, Vinicio is talking about the earlier part of your talk with high pressure, high flow left to right shunt lesions. Do these considerations apply to those patients as well as what we used to call idiopathic pulmonary hypertension?
Absolutely. What we see is definitely also part of the spectrum of pathology that we will see in patients with congenital disease. In fact, we group them together in there are 5 different groups of pulmonary hypertension, but congenital, idiopathic, familial, are all grouped within group 1 because the pathology is the same. So indeed, part of the work that we're now continuing in collaboration with Karen Tran-Longmark is taking samples from patients with congenital heart disease associated PAH to analyze the anatomical landmarks to see how the lesions compare to those seen in that setting.
Thank you. And before I'll ask the very last question, so I want to compliment you. We've received comments about your talk being a model of clarity, and it was really, really well done. Outstanding presentation. Great job. All right, so I'll just ask one more question. This is for me. Pulmonary arterioles classically can't respond rapidly to changes like to a loss of circulation with a blood clot, like when you have a pulmonary embolus. And usually the rapid responses you see are with the vasovasorum from the bronchial arteries, which you talked about at the very beginning.
Yeah.
So when you have a pulmonary embolus, so you get a big clot going down your pulmonary artery, and it drives the bronchial artery angiogenesis around the occluded pulmonary vessel. Is that process in any way related to pulmonary arterial hypertension?
That is a really good question. And the observation that we can actually see these lesions associated with plexogenic lesions associated with vasa vasorum seem to indicate that there may be areas where these seem to be compensatory mechanisms, or they're there for a reason. They're just not working the way they should. So in this context, is likely that similar mechanisms may be at play. It would be interesting to consider whether in CTEPH we may see some of these same lesions. Now, it's really interesting. To the best of my knowledge, nobody has shown that plexogenic lesions can be seen around the areas where you actually have the active clot, like as a way to sort of create a bypass setting. They have been seen in the distal periphery. So I think it's a really important question whether there's an overlap there in terms of mechanisms and genetics. It's something that, to the best of my knowledge, hasn't been explored.
Great. Well, let me thank you once again, Vinicio. That was a wonderful presentation.
Thank you.
We will, I guess, take the rest of the questions offline, but great job.
Thank you so much.
Okay.